that will help pass news out into our community about how we're doing and why we're on this venture of the conversion agreement. So I have a couple of prepared comments I'd like to go through. Apologize for reading some of it, but I want to make sure we cover a few key points. We're in the preliminary stages of a business model for our county hospital to move to a private, not-for-profit entity. And there are several reasons why this change is being implemented now, and there are many steps to be completed, a tremendous amount, I might add. But according to a recent study in Hospital and Healthcare Networks, small to medium community hospitals should plan for direct payment reductions of 14.5% over the coming years. We should do everything we possibly can, and we're all in violent agreement about this at the hospital and in the entire management team and board, to try to mitigate that impact as we move forward. Small rural hospitals across the country are affiliating with large hospitals in order to do just that by sharing resources and talent. The affiliation has the potential to result in cost sharing, discounts on purchasing, and lower interest rates on credit. Currently, there are 26 critical access hospitals in the state of Idaho. There are 44 total healthcare facilities in our state, and out of the critical access, 8 of those have management affiliation agreements. There are several different models that you can have a hospital organized under. And we're currently a county hospital, and there are 9 of those in our state. There are, I believe, 11 district hospitals, and then there are 7 not-for-profit. So you can see that there's a lot of different ways to be organized. There are also, in the larger hospitals, several for-profit entities. ERMAC is that model. I think everybody can remember our recent past, and in early 2009, we were on the brink of major problems in trying to sustain our hospital, and kind of a distress call went out to avoid maybe even bankruptcy for our county, and the trustees began researching operational opportunities and options, and with an objective of long-term sustainability. Since then, the leaders of our county commissioners and board considered available alternatives to our current business model. It's been discussed and rediscussed many, many times in both formats, at the county commissioners chamber as well as at the hospital board of trustees. As we got closer to an understanding of what our options might be, there was a recommendation that a private not-for-profit might be an ideal option for our community. Changing the structure will largely remove the county from its current risk position. However, county involvement will also be retained through a 99-year operating lease between the new entity, which would be Teton Valley Healthcare, Inc., as a private not-for-profit, and the county. There's also a liquid asset transfer agreement that provides a revenue stream back to the county. It's about $70,000 a year, and with options, if our profitability improves, to move another amount forward also to put back in the coffers for the county. This model, we hope, is the right direction to go to reduce our operating costs, increase our efficiency, and expand our services. Of recent, we just finished our fiscal year. On the 30th of September, and one of the ideas brought to us from Bingham was the visiting specialist model and how to fortify it. That particular model last year added an additional $900,000 in revenue to the hospital. Without that expertise or knowledge of how to make those models work in a critical access hospital setting, we would have been in a much tougher position. So we've had this 2-year relationship on a consulting basis with Bingham, and now we're moving to a model that would actually be on a management basis. And so those are agreements yet to be crafted. Some of those areas would be difficult to answer as questions tonight, but we'll do our best to inform you with everything that we're aware of and understand in the process going forward. Any other comments from either?
No, you did a very good job.
Thank you. I think we've made our statement.
Perfect. All right. I want to remind the panel that we the questions that we have here. It's as we've been, as this conversion process has been going on, we've had a lot of questions from the community, and these are kind of a compilation of the most commonly asked questions to us. And so I wanted to ask the panel these questions to hopefully answer any questions you have before we turn it over to you. The first question: it seems using Teton Valley Hospital costs a little more than going out of Valley. How will this conversion affect patient costs and service?
Should I do it?
Sure.
Okay. We run on a particular model of providing service that has a 24/7 cost, and so utilization is what drives costs down. And so there are going to be some services that we provide. However, since Jason started with us last January as our controller, he brought tools to us that allowed us to do an analysis of our costs for the services we provide. And it's called the Charge Master. And it allowed us to compare our position on fees with others. And we found a great majority of our services were, if not lower, may even been the lowest of all the comparisons that we made. There are other services, in order to bring them to our valley, that we know will cost more, but we're doing it because of the convenience and what a full hospital should offer to a community. So we hope that as we get stronger financially, that we can have that teeter-totter between those that we know maybe we're under and those that we know are over, that we can do a balancing act to try and average out those costs to the best possible level for our community.
All right, next question.
Scott, excuse
Yes.
me, I'm sorry. Do we have an opportunity to ask questions in somewhat of a rebuttal to the answers?
Do you have like an additional comment with this?
Yeah, something that's directly related to that?
Yeah, we can do that today. Sure. So we don't have to go back to it later. Question.
It's my understanding that as a rural hospital, that you've been allowed to charge higher costs than the metropolitan hospitals.
Do you want to go to that?
The charging or the price setting really is specific to the area, to the location. As a rural hospital, our costs are higher because of utilization, as Virgil pointed to, and because we don't have necessarily the volumes that the lower or that the metropolitan areas have. It really is based off of supply and demand at some level, but really it comes down to being able to provide a 24/7 full service hospital in a rural area. The price setting really is individual based.
I understand that completely. However,